regardless of baseline characteristics. Thank you.
Great. Good afternoon, everybody. And on behalf of the TUAB0203 investigators and my co-authors, I'd like to thank the organizing committee for the opportunity to present this analysis that suggests a high SVR rate in co-infected patients, regardless of baseline characteristics treated in the TUAB0203 study. So these are my disclosures and those of my co-authors. As we've already heard, co-infection with hepatitis C is a prominent finding in those with HIV. And co-infection is associated with more rapid liver disease progression, non-hepatic organ dysfunction, and increased overall mortality when compared to mono-infected patients. With potent antiretroviral therapy, liver disease remains a leading cause of death in co-infected patients. And thus, the guidelines reflect this in identifying co-infected patients as a high priority for HCV treatment. Additionally, the recommendations on how to treat those patients really follow in line directly with the recommendations for treating a mono-infected, HCV mono-infected population. A little more background about the 3D regimen. It's a regimen consisting of umbitasvir, paritaprevir, which is boosted with ritonavir, and dasabavir, administered with or without ribavirin, and it's approved in 49 countries for treatment of genotype 1 HCV infection, including those with co-infection. The TUAB01 study was a study of co-infected patients treated with or without cirrhosis who were treated with 12 or 24 weeks with or without ribavirin with this regimen. What's depicted in the graph here are the primary SVR12 rates in the intention to treat analysis, and you can see 94% SVR12 rate in the 12-week arm and 91% in the 24-week arm. The objective of this analysis was to go back and examine the SVR12 rates by different baseline demographics and disease characteristics. So again, to reiterate, the 3D regimen consists of umbitasvir with paritaprevir boosted with ritonavir in one tablet. That's co-administered with dasabavir, an NS5B non-nucleoside inhibitor, which is dosed separately. Again, in patients with genotype 1A, this is given with ribavirin. So the key eligibility criteria for the TUAB01 study, patients 18 to 70 years of age, BMI range from 18 to 38. It was a genotype 1 only study with a plasma viral load greater than 10,000. Patients could be treatment naive or treatment experienced with fairly standard definitions for those who were treatment experienced in terms of relapse, partial, or no response. They were eligible if they had cirrhosis. It had to be child's Pu-A cirrhosis. And then HIV infection had to be well controlled, as you can see here, with a CD4 count above 200 or a percentage above 14%. The antiretroviral regimens allowed only consisted of atazanavir or raltegravir-based regimens. Baseline demographics and disease characteristics for the two populations. You can see here predominantly a male study. Black race was present in about a quarter of patients in both arms. Fibrosis stages are listed here, and you can see 6 patients in each arm were designated as F4 or cirrhotic. The IL-28B genotypes are shown here, and again, predominantly a genotype 1 study, about 90%, and HCV RNA around 6.5 logs. If we look at prior treatment experience, you can see 5 patients in each arm were prior null responders. In terms of other characteristics that may be associated with reduced response to traditional HCV therapies, diabetic patients, 7 patients all randomly assigned to the 24-week arm. A third to a half had a history of depression or bipolar disorder, and a quarter to 40% had a history of injection drug use. Similar to the previous study, we saw a well-preserved CD4 count overall with a mean above 600 CD4 T cells, and again, a relatively small percentage that were less than 350. The breakdown of their antiretroviral regimen you can see here with atazanavir in about 50% in the 12-week arm and 38% in the 24-week arm, and raltegravir 48 and 63% respectively. So to analyze baseline factors, we actually looked at a modified intention to treat analysis, eliminating patients who had non-virologic failure. And when you go through and do that, you're left with 30 patients in both arms. The patients that were excluded was 1 patient from the 12-week arm who withdrew consent at week 10, and 2 patients in the 24-week arm who actually had pretty well documented reinfection after the SVR time point before SVR12. This was documented by sequencing of the virus and comparing to their baseline sample. So we were left with 2 virologic failures, 1 in the 12-week arm and 1 in the 24-week arm. The patient in the 24-week arm had a breakthrough at week 16. The patient in the 12-week arm experienced a relapse by SVR4 time point. So now I'm going to take you through a series of slides that just looks at the various baseline demographics and disease characteristics for these two patients. Here we see by age, one patient was less than 55, one over 55. Both were males and both identified as non-black race. In terms of their HCV subtype and viral load, both were genotype 1A and both had a high baseline viral load, at least above 800,000 IUs per mil. If we look at their IL-28B genotype, both were IL-28B TT, so the historically unfavorable genotype with interferon-based therapies. By their prior experience, as you might expect, both were also prior null responders. And if we look at cirrhosis or disease stage of their liver disease, both actually were cirrhotic patients. One patient was documented as cirrhotic by a fibroscan, and the other patient had a historical biopsy that showed cirrhosis a number of years before enrollment in the trial. Now to look at some other characteristics in terms of BMI. Both patients had a BMI less than 30 kilograms per meter squared, and neither patient was diabetic. If we look at history of injection drug use and concomitant psychiatric disease, you can see neither patient had identified as a former injection drug user, although both patients did have a history of depression or bipolar disorder. And then if we look by antiretroviral regimen, both patients happen to be in the raltegravir arms in the 12 and 24-week duration treatments. CD4 count here, both patients, as you might expect, given the overall CD4 count for the study above 600, had CD4 counts above 500 at study entry. So in conclusion, in this HCV genotype 1 HIV co-infected study of the 3D regimen plus ribavirin, overall high rates of SVR12 were achieved regardless of baseline host viral and disease characteristics, regardless of whether they were treated for 12 or 24 weeks. Only 2 of the 62 patients had a true virologic failure. And I would point out that certainly based on the label recommendations, a genotype 1A patient with cirrhosis, it would be recommended to treat 24 weeks with ribavirin. And so one of these patients only received 12 weeks with ribavirin, which would not be consistent with current labeling indications. And as could be expected, both patients who did experience virologic failure had genotype 1A, prior null response to PEG and ribavirin, IL-28B TT genotype, and were cirrhotic. The 3D regimen with ribavirin co-administered with atazanavir or raltegravir antiretroviral therapy was well tolerated and no patients discontinued due to adverse events. And just to acknowledge my co-investigators, the other authors on the preliminary Turquoise 1 results that were published in JAMA, and certainly the patients for enrolling in this study.
Thank you. We have about 4 minutes for questions. And just to make you aware, we have 7 presentations in this session, which is why we're being particularly strict on time. Most of the other sessions have 5 or 6 presentations. So questions to Dr. Wiles? Just to ask, in your first slide in the introduction, you stated that the prevalence of HCV in your HIV-infected population was 20 to 40%. Where is that sourced from? Because that was very different from the presentation earlier where they cited 10%.
Yeah, so it depends. I mean, there was an ACTG study that looked across the ACTG networks. That was on the lower end of that estimation. That's down to 20%. Obviously, you can get as high as 80 to 90% in some areas in the United States around Baltimore where there's lots of injection drug use and combined. But the lower bound certainly is from the ACTG cohort. And in San Diego, anyway, we have about a 22% prevalence.
So this is more just to hear your own speculations, but there was a number of diabetic patients, and there is a relationship between hepatitis C and insulin resistance. So in this study, or in your experience with the use of other DAA regimens, have you seen cases where the ability to manage diabetes is improved, or there's been any change in that outcome?
Yeah, that's a great question. In this study, I don't think we noted any. I don't think fasting insulin levels or things like that were collected to calculate like a HOMA-IR and see if that improves. And I would say, at least anecdotally to this point, I haven't really noticed a profound effect of patients we've treated in our clinic that have been cured. Like they can come off their oral hypoglycemics or something like that. I think it's something interesting, obviously. You know, now there's some controversy about that association